Hello, and welcome to this Touch Talk activity. My name is Jennifer Sherr, and I'm a pediatric endocrinologist at the Yale School of Medicine in New Haven, Connecticut. Today, we'll be discussing the following topics: the impact of diabetic ketoacidosis on people with diabetes and the importance of preventing the condition, the risk factors for developing DKA and its pathogenesis, and finally, the available and emerging tools that may help prevent DKA, including ketone monitoring. So let's start by discussing the impact of DKA on individuals with diabetes. When we think about hyperglycemic emergencies, there are two serious conditions. Just last year, there was an excellent consensus report published in Diabetes Care about hyperglycemic crisis in adults with diabetes. The first is diabetic ketoacidosis, and today's discussion will primarily focus on this condition. When we think about individuals presenting with DKA, it more commonly occurs in individuals with type 1 diabetes who tend to be younger. It develops over hours to days, and people usually present and they're alert at presentation. And ketoacidosis is the predominant hallmark of this condition. Now, when speaking about hyperglycemic hyperosmolar crisis, this is more often seen in individuals with type 2 diabetes and older adults. This has a longer insidious development that occurs over days to weeks, and changes in cognitive status are common. So individuals who have HHS have significant extracellular fluid volume depletion, and they present very dehydrated. Hyperosmolality is a hallmark of this condition. And in my experience, I've seen people come in with extremely high glucose levels and extremely high sodium levels. Glucose levels that are in the 1500s. It's astounding. And amazingly, as these individuals are treated, what we see is over time, their mental clarity improves, but you have to be very cautious when treating this condition. But the focus of today's talk is really going to be about diabetic ketoacidosis. We know it's caused by an imbalance in hormones. In the setting of low insulin levels, the body begins to look to alternate sources of fuel, and this includes gluconeogenesis and ketone production occurring. This is further exacerbated by a glucose overload, which occurs as people are going ahead and eating foods, but because there's no insulin available, they cannot effectively or efficiently utilize that glucose. In addition to that, there's an increase in counter-regulatory hormones, which spike during times of stress and cause glucose levels to further increase. So when we think about DKA, it's characterized by a triad of features. Diabetes, the D in DKA. So that means individuals present with blood glucose levels that are over 200 or a prior history of diabetes. The K stands for the presence of ketonemia or ketonuria. And the A stands for acidosis. So individuals presenting with DKA have an arterial pH of less than 7.3 or serum bicarb less than 15. So why is it important to note that individuals coming in with diabetes may not have elevated glucose levels? And it's due to the fact that some individuals present with euglycemic DKA, meaning that their glucose is not elevated at the time of presentation. So if somebody has a history of diabetes, we want to be thinking that they could present with DKA despite not having an elevated glucose level. And this is especially true if an individual is taking SGLT2s, as this can lead to lowering of glucose levels through glucose excretion in the urine. So what are the presenting symptoms of someone coming in with DKA? The first thing that you often notice may be abdominal pain. People may then go on to have nausea and vomiting. As glucose rises, the body tries to get rid of the extra glucose, and so there's this vicious cycle of polyuria and polydipsia. People are trying to get rid of all that extra glucose, and that's going to then lead to dehydration as we're drawing all the water out. The smell of acetone may be present, and if anyone has ever smelled juicy fruit gum, it always reminds me of that scent. And people can also have altered sensorium or present with Kussmaul breathing, which is deep labored breathing. So people are really trying to exchange air. Now, often in pediatrics, we find many kids present in DKA with nausea and vomiting. And oftentimes, families may stay home thinking about the fact that their child has a GI bug. It's nothing to worry about. But in truth, nausea and vomiting in anybody with diabetes should be an instance where we're thinking about whether or not DKA can be presenting. So we know there's significant morbidity associated with DKA. Individuals with history of DKA have a high risk of recurrence. Those with mental health disorders also have a higher frequency of DKA. And when we think about DKA, the rate of hospital admission is 3.3 times higher for DKA as compared to severe hypoglycemia. And we know DKA and severe hypoglycemia are the two acute complications that individuals with diabetes experience. Why don't we see as much severe hypoglycemia? It's probably due to the fact that people are treating with glucagon at home. We may not be aware, but if somebody has DKA, they come in when they're very sick and need medical intervention. DKA is also associated with increased mortality rates. For those discharged after a DKA episode, the risk of a 1-year age-corrected mortality is 13 times higher than the general population. When just focusing in on those aged 15 to 39 years, risk of mortality is 49-fold higher than the general population. And approximately 50 to 90% of pediatric diabetes-related deaths are secondary to cerebral edema, which is a complication of diabetic ketoacidosis. One thing is clear: earlier recognition and diagnosis of ketosis is essential to prevent further metabolic deterioration. Again, we should focus on counseling those who have a previous episode of DKA. So anytime a child comes in and is diagnosed with DKA, we spend the next day after we've resolved the acidosis, we're transitioning them back to their usual therapy, really trying to break down what led to this. What happened? Oh, you know what? I think I missed a few insulin doses. Or, turns out that the child was sick and we were thinking it was just a GI bug. And so really helping families take this top of mind and taking those opportunities to speak to families about DKA. We believe, according to the International Society for Pediatric and Adolescent Diabetes, we should provide education about DKA at the time of disease diagnosis, opportunistically, so if somebody comes in with a case of DKA, and then at least annually, so that we can be thinking about ways to intervene earlier. So what's the pathophysiology of DKA, and how does this impact our management of the condition? When we think about risk factors for DKA, there are modifiable and non-modifiable factors. Adolescent age is one of the non-modifiable factors. Adolescents feel like they're invincible. Clearly, this is not going to happen to them. Female sex is another non-modifiable factor. And some of this may be due to the fact that people realize if they omit insulin doses, they tend to lose weight. And as women may be concerned about body image, they may leverage this to their advantage. Those with a history of migration or from low socioeconomic status are also known to have an increased risk for DKA. Now, what about those modifiable risk factors? Obviously, somebody with a prior history of DKA is going to be at increased risk. And those are the individuals that when they come in with an instance of DKA, we're going to want to problem solve and try and figure out how to avoid this in the future. Someone with an elevated A1C likely indicates that they're struggling with engagement with insulin therapy. And so due to this, we really want to talk to them about ways to make sure they're engaging with insulin therapy, offering technologies that may help them do this. And individuals on SGLT2 therapy also have an increased risk of DKA. Finally, individuals with alcohol or substance use or comorbid health conditions may also have an increased risk of DKA. So keeping this all in mind, as we're seeing individuals in clinic, we may want to focus our education if somebody has one of these modifiable factors, trying to go ahead and address that modifiable factor, and really focusing in on education about how to detect and then intervene should ketosis be detected. So what are the most common triggers of DKA? At the very top of the list, we see suboptimal engagement with treatment plan or missed insulin doses. And this is the majority of cases that I see clinically. In addition to that, we can have infection, particularly UTIs or pneumonia. I don't see this as much as a pediatrician, but myocardial infarction could lead to DKA. In the event of trauma, DKA can develop. Individuals with stroke can have DKA. Alcohol or substance use, pancreatitis, and pulmonary embolism. And it's also important to note that at disease onset, approximately 30% of individuals diagnosed with type 1 present in DKA. And so there's been a lot of efforts about how do we screen the population to identify those who are at risk for developing type 1 and hopefully minimize their presentation with DKA at disease onset. So what would usually happen in an individual who does not have diabetes when glucose levels are elevated? So insulin production from the pancreas would increase, and this would then suppress hepatic glucose production. In addition to that, insulin's going to work on the skeletal muscle and promote glucose uptake in both skeletal muscle and adipose tissue. And the cumulative effect of all of this is going to be lowering of glucose levels. But DKA is driven by a number of factors. So individuals with diabetes have an absolute insulin deficiency. And so even though glucose is being ingested, the body falsely thinks that it's starving. So we turn to alternate mechanisms to provide fuels. And those fuel sources can come from increased gluconeogenesis and glycogenolysis from liver and muscle, as well as lipolysis and generation of fatty acids. All of this in turn leads to increased ketone body production with subsequent hyperketonemia and eventual ketoacidosis. The hyperglycemia, dehydration, and hyperosmolality that ensue are accompanied by electrolyte imbalances and diuresis, which decrease blood volume and cause lactic acid to build up. So individuals presenting with DKA may have low pH, there's acidosis detected, and people will say, oh, they've got high beta-hydroxybutyrate acid levels, but in addition to that, they may have high lactic acid levels. At the same time, the GFR is reduced, which again limits the ability to excrete glucose, which further worsens the hyperglycemia that's present. Finally, as mentioned earlier, there are electrolyte imbalances. As insulin function is down, acidosis occurs, and the body tries to buffer this by pushing hydrogen into the cells and exchanges for potassium. So potassium is going into the extracellular space. So intracellular potassium is low, and as osmotic diuresis occurs, there's loss of potassium in the urine. So people with DKA can present with quite low potassium levels. Some folks will have normal levels, and some folks will have high levels. The important thing is to understand that there's total body potassium depletion. So the goal of DKA is to counteract the pathophysiology underlying the event. The biggest thing in my mind is to normalize that acid-base disturbance. And the way we accomplish this is with insulin therapy. So really, the hallmark is going to be starting IV insulin. In some situations, you can use subcutaneous insulin therapy, but insulin therapy is going to be what goes ahead and corrects that acidosis. Now, insulin therapy is also going to normalize glucose levels, but that's really a secondary aim. I'm not working to drive glucose down rapidly, I'm working to correct the acidosis. The other treatment aims are really going to lie around going ahead and making sure we normalize circulatory volume and we ensure electrolyte replacement as needed. Oftentimes, people are going to need potassium replacement. Now, in pediatric cases, there's a need to be more cautious with treatment because there's a greater concern for cerebral edema. So again, you'll find that the focus is going to be on correcting acidosis, reversing ketosis, and that's going to be through the use of insulin therapy. And we're gradually going to restore glucose concentrations to near normal. Our other aims are going to be to monitor for signs of acute complications, specifically cerebral edema. So in our hospital, we Q1 hour mental checks so we can assess their mental status and make sure things are not deteriorating. We want to restore that electrolyte balance to normal. And as I said earlier, identify and treat any precipitating events. I was recently on call and there was a young man who came in who he has had a number of presentations with DKA, and he has a quite difficult social situation. And when he came in to present, we found out that he had been suspended from school. Now, we've gone ahead and invested the school nurse to give his insulin therapy, his long-acting dose, so that we can assure we can avoid DKA. While he was in school suspension and home, nobody was overseeing his long-acting insulin. So it was evident that that insulin omission led to a situation of DKA, and we could problem solve and talk about the importance of letting us know if he's not in school. So for management of DKA, we have our 3 pillars. Again, insulin therapy, which will be the crux of correcting acidosis, as well as lowering glucose. Fluid resuscitation, electrolyte replacement. A few caveats in peds. We always recommend giving fluid replacement an hour prior to starting insulin therapy. So most kids who come in with DKA, they're going to recognize people have nausea, vomiting, they may be dehydrated, and so we immediately start with normal saline boluses. And oftentimes people get 2 fluid boluses before we can even get IV insulin therapy started. Importantly, sometimes we see elevation in potassium levels. So if a potassium is over 5.5, we want to hold on adding potassium to the bag until we establish urine output. We know eventually that potassium is going to be needed because as we correct that acidosis, we're going to recognize that there's total body potassium depletion. So now we know how to treat DKA, but how do we prevent and monitor for it? The only way to prevent DKA is to educate those at risk regarding DKA and providing anticipatory guidance of when to check ketones and what to do if ketone levels are high. It's been noted that the rate of hospitalization for DKA has been increasing. And in the past few years, there was a survey conducted in Germany and Switzerland, and they found that 32% of people with type 1 were not even familiar with the term of DKA. What becomes even more concerning is when they asked the physicians of those individuals with diabetes, do they think their patients are knowledgeable about DKA? They often overestimated what these individuals might know about the condition. And again, according to ISPAD guidelines, it's recommended to discuss DKA mitigation at diagnosis, at least annually, and opportunistically. And if someone has an episode of DKA, we should always use it as a learning opportunity. And to do this, we need to engage with people with diabetes to identify triggers and come up with a plan to prevent recurrence of these events. So how do we measure ketones currently? Currently, there's 3 main measures that are used. The first is capillary fingerstick measures with a meter that measures beta-hydroxybutyrate. There's also the ability to do breath acetone testing, and finally we can measure acetoacidic acid from the urine. Now it's important to note that the primary ketone produced in DKA is beta-hydroxybutyrate, and as ketones are cleared, there is conversion to acetoacidic acid. But there's a delay because the acetoacidic acid needs to be excreted with each void. So if we're just relying on acetoacidic acid measures, it's not going to provide the most accurate assessment of ketone status. Despite having methods to measure ketones, there are limitations to the strategies that are currently available. The first is that people with diabetes need to initiate the testing. They need to be thinking about, do I need to measure my ketones in this instance? And it also requires carrying strips and making sure these test strips are not expired. For urine ketone testing, people have to think about, am I out? Can I find a bathroom? Is it going to be easy to go ahead and test for ketones in this instance? And if they're in their home setting, urine ketone testing can be impacted if the bottle isn't completely closed or if those strips are subject to humidity. I don't know about your bathroom, but my bathroom has a lot of humidity in it. And humidity can lead to those test strips providing false negative results. In addition to that, We know that breath testing is expensive. It's not really adopted by the diabetes community, more often used for those who are maintaining a low carbohydrate diet. And finally, capillary measures may be less accurate at very high levels. I think the bigger issue with capillary measures now is that most individuals with diabetes are using continuous glucose monitors, and people have gone away from carrying fingerstick measures with them. People don't like testing fingerstick assessments if they know they can get their glucose levels on demand constantly. So it's hard to say, I'll just carry around this blood ketone meter whose strips may expire, and I don't know that I'll ever need them. So we have a lot of issues in facing assessment for ketones. Now, a survey that was conducted by the Type 1 Diabetes Exchange Registry back in 2015 asked almost 3,000 individuals with type 1 across the age span, what are you doing in terms of ketone testing? 32% of this cohort reported they don't even have testing supplies at home. 30% of individuals reported that they never check ketones, and 20% reported rarely checking for ketones, even in the instance where they had hyperglycemia, which in this survey was defined as glucose levels over 300. And finally, as you'll see in this last graphic, 38% of individuals never checked for ketones when they were nauseated and or had vomiting. Importantly, if you look at the primary study here, you find that the youngest age group, kids 6 to 13, actually did much better with ketone monitoring. Why was that the case? Their parents were doing it for them. So as we get past that age, people feel more invincible. I've never had ketones before. I don't need to worry about it, which is not true. So we know continuous glucose monitoring has become the standard of care for individuals who require insulin therapy. It provides much better understanding of the glycemic fluctuations that people experience. So as you can see here in this graph, we see that the blue dots represent capillary fingerstick measures, and the orange line is representing that continuous glucose monitoring data. And so with a CGM data, we can look at things in real time or retrospectively. I always hearken this back to if you go to a sporting event and you take a few photos, you have no idea what happened in the game. If you have real-time video, we can understand exactly what happened, go to playback, see what caused things to occur. So CGM is so much more powerful in helping us optimize therapy for people living with diabetes. Now, use of CGM has been found to decrease the rate of DKA hospitalization. And this is true regardless if an individual has type 1 or type 2 diabetes, where there's an almost 50% reduction when CGM is added to the treatment regimen. So as we think about an ideal ketone monitoring device, what would we want to look for? I think obviously trying to find something that is just going to go ahead and passively collect the data is going to be huge. We don't want the individual with diabetes to be thinking about the need to go ahead and take the test. And if we can think about technology that could be integrated with something that a person with diabetes is already using, is going to help make that system more accessible. So if it's combined with glucose management system, they're already wearing a device, they just have the benefit of getting something else measured, I think uptake is going to be much easier. We want to make sure future monitoring systems are going to measure ketones over a relevant and dynamic range, meaning knowing if we're safe when ketone levels are low and understanding how high we're getting and when to intervene as ketone levels go up. And I think one of the most critical things we've learned with continuous glucose monitoring is more data is not always better. And what do I mean by that? If ketone levels are in a normal range, I think it would be best not to show anything. Give somebody a green light, things are good, don't worry about this, and only alert them when there's the need to take action. And why is this the case? When CGM initially came out, we find many individuals had alarm fatigue that developed. This thing is going off, I don't know what it means, should I do something at this point? And that led to, at times, discontinuation of devices. So the goal here is to really be thoughtful about how we think about what the data should be shown as, where alarms should be set, and making sure we're not setting too many alarms that could cause alarm fatigue, and each alarm needs to be actionable. So we know that continuous ketone monitors are in development today, And similar to continuous glucose monitors, these sensors would sit in the interstitial space under the skin and through an enzymatic reaction would detect beta hydroxybutyrate levels. As a reminder, that's the predominant ketone in DKA. In fact, continuous ketone monitoring technology is already being used for clinical trials. So up until now, we have not been able to see use of SGLT2 inhibitors for individuals with type 1 diabetes. Why? Regulators are concerned about the risk of euglycemic DKA. So in thinking about how we might be able to leverage this type of medication for people with type 1, integrating the use of CKM could be the safety net that we require. So you'll see that these first two trials are exploring exactly that, and other trials of CKM remain ongoing. At the most recent American Diabetes Association scientific session, which was just held at the end of June, there was some data that was presented on the use of continuous ketone monitors. One presentation from a group out of Toronto showed the assessment of the SciBio CKM as compared to capillary ketone measures. And what they did in this situation is they looked at individuals with type 1 who were on automated insulin delivery systems and were maintaining a ketogenic or a low-carb diet. And what they found was that the vast majority of ketones assessed were less than 0.6. Less than 0.6 is normal, so it was very reassuring to see that. However, 2.1% of the time, people were having ketone levels that exceeded 0.6. And 2.1% of the day is about 30 minutes a day. And that could be clinically important. Now, the investigators in this study noted that their measures of accuracy seemed to show that their CKM and capillary measures were nicely correlated, suggesting that this could be a very useful device in future clinical application. The final presentation I want to alert you to is an entire symposium that was dedicated to continuous ketone monitoring. And I got to be part of this with Dr. Ketan Dataria, Lori Leffel, and Rich Bergenstahl. And so I think today has provided some initial exposure to the potential for CKM technology, but if you want to learn more, I would definitely recommend checking it out. Thank you for your attention, and I hope you found this to be a useful learning experience on DKA.